Welcome! As pharmacists, we are in a unique and powerful position when it comes to HIV prevention. So today, we're going to get right into the practical, need-to-know info on PrEP and PEP. My goal is to equip you with the key counseling points that will make a huge difference for your patients. All right, let's jump right in. Here's our game plan. We're going to start with the big picture, the 4 pillars of prevention. Then we'll dive deep into PrEP, which is all about being proactive, and PEP, that critical 72-hour emergency option. And we'll wrap up with what I think is the most important part, the conversations you have face-to-face with your patients. So, why does this matter so much right now? Well, this number tells a big part of the story. With over 62,000 people in Canada living with HIV, our work in prevention isn't just important, it's absolutely critical. Your expertise right there in the pharmacy can literally change the trajectory of this epidemic. Okay, first things first, let's lay out the framework. When we talk about using antiretrovirals for prevention, it really comes down to 4 main strategies, or pillars. This helps us see exactly where PrEP and PEP fit into the overall picture. So here they are, the 4 pillars. You've got treatment as prevention, which is huge, and of course, protecting babies during pregnancy. But for our purposes today, we're zeroing in on those last 2, PrEP and PEP. Why? Because these are the areas where you're most likely to be counseling and dispensing to people starting a new prevention journey. All right, let's get into our first deep dive, PrEP. The best way to think about it is as a proactive shield. We're going to cover exactly who should be using it, the safety checks you have to do, and how we manage these patients over the long haul. So what is PrEP exactly? At its heart, it's a prevention strategy for someone who is HIV negative but has an ongoing risk. Now, here's a massive clinical pearl. You never, ever start PrEP if you even suspect an acute HIV infection. You have to confirm they're negative first. Starting it in someone newly infected is a recipe for developing drug resistance. Before a single pill is handed over, there's a non-negotiable 3-step process. You start with a really good clinical history and risk assessment. Then, a physical exam, looking for any signs of an acute infection. And only then do you move on to the baseline labs. Okay, looking at these labs, one of them stands head and shoulders above the rest in terms of importance, the HIV test. It must be negative. Like I said, giving a 2-drug PrEP regimen to someone who is actually HIV positive is essentially undertreating them, and that's how resistance happens. The other labs are all about setting a crucial safety baseline before you start. So when it comes to the actual drugs, you've basically got 2 main players. Think of this as your cheat sheet. On one hand, you have emtricitabine/TDF. It's cheaper, there's a generic, and it's approved for everyone. On the other hand, you have TEF. It's much kinder to the kidneys and bones, but it's pricier. And here's the kicker, it is not indicated for receptive vaginal sex. There's just not enough data. That's a huge deciding factor. All right, this is a big one. This is a counseling point you absolutely cannot skip. You have to say it clearly every single time. PrEP is amazing at preventing HIV. It does absolutely nothing for gonorrhea, chlamydia, or syphilis. Condoms are still a vital part of the toolkit. Now, PrEP is definitely not a prescribe and forget kind of medication. This 3-month check-in is the absolute standard of care. And see that last point, dispense no more than a 90-day supply? There's a reason for that. It forces the patient to come back for those crucial safety checks, especially the repeat HIV test, before they can get their next refill. Okay, so we've covered the proactive shield. Now, let's flip the script. Let's talk about the emergency measure, what happens after a potential exposure. This is post-exposure prophylaxis, or PEP. First thing you need to know is that PEP comes in 2 flavors. There's occupational PEP, think of a healthcare worker with a needle stick injury. And then there's non-occupational PEP, or NPEP. That's what you're way more likely to see in community practice. It's for exposures from sex or from sharing drug equipment. The situation is different, but the urgency is identical. If you remember one thing about PEP, please let it be this, the 72-hour rule. Time is everything. The clock starts ticking the second the exposure happens. You want to get this medication started within hours, because after that 72-hour window slams shut, its effectiveness plummets. This is a true medical urgency. So a patient comes to you, how do you know if PEP is even necessary? Well, this table is your guide. It helps you quantify the risk. You can see right away that receptive anal intercourse carries the highest risk per act, with needle sharing not far behind. This data is exactly what clinicians use to decide whether to pull the trigger on a PEP prescription. When you see a script for PEP, this is what you should expect. It's always a full 28-day course, and it's a 3-drug cocktail. The backbone is usually emtricitabine/TDF, just like PrEP, but then you add a powerful third drug, typically an integrase inhibitor like raltegravir or dolutegravir. They're popular because they work fast, are really well tolerated, and have fewer drug interactions.
All right, let's pull all these threads together. Because the drugs themselves are just tools, right? The real magic, the thing that makes these strategies work, happens in the conversations you have with your patients.
This right here, this is one of the most powerful stigma-shattering messages in modern medicine. You equals you. Undetectable equals untransmittable. You need to know this and say it with confidence. If a patient tells you their partner has HIV but has been undetectable for at least 6 months, the risk of them getting HIV sexually from that partner is 0. That completely changes the conversation about needing PrEP or PEP. These are the nuanced situations you'll run into. You'll need to know what to do for pregnant patients or how to manage someone with Hep B. But I really want you to focus on that third point, the repeat net PEP user. If someone keeps coming back for PEP, that's a huge red flag for ongoing risk. It's your opportunity, your responsibility really, to pivot the conversation to PrEP. It's a much better long-term strategy. So, what's the big takeaway here? It's not about becoming an HIV specialist overnight. It's about weaving these questions and these conversations into your daily workflow. It's about creating a space where people feel safe to ask. By being ready with these tools, by being that trusted resource, you become a cornerstone of HIV prevention in your community. Thank you.